this is a very interesting case. We have a gentleman who is middle-aged and is having repeated transient ischemic attack. Transient ischemic attack means mini stroke. Generally, stroke will manifest as weakness at one half of the body, speech weakness, arm weakness, or visual disturbances, disturbance of balance, and these are the signs. Typically, we say it's a B fast. B is loss of balance, E is ocular symptom or eye symptom, F for facial weakness or drooping of the face, one angle of the mouth, and A for arm weakness, S for speech weakness, and then this is the time to rush to a stroke center because the patient is experiencing a stroke. So to understand whether the patient is having a stroke or not, please remember FAST, F-A-S-T, and we have added B-E, B to that. So it's a B fast. The symptom of stroke is B fast. B is loss of balance, E is eye or ocular symptom, F is facial weakness, A is arm weakness, S is speech weakness, and T is time to rush to a stroke center. So what are these weakness that could happen? So B for balance, there is a loss of balance. A gentleman who was able to walk comfortably suddenly lose balance. And E is ocular symptom. A gentleman who was perfectly fine can experience blurring of vision or sudden loss of vision, which he recovers from, which is called amaurosis fugax. And F for facial drooping. The gentleman who was perfectly fine, suddenly you see that angle of mouth is deviated to one side. And then A is arm weakness. The gentleman who was perfectly fine, not able to hold the pen or hold a phone, feels there is a weakness on one side of the body, the hand or hand and leg both. And then S is a speech weakness. The gentleman who was perfectly fine suddenly start experiencing slurring of speech or no speech. Then we can expect that the patient is probably having a stroke, and then it's time to rush to stroke center. So this gentleman had multiple TIA or mini strokes, and we examined, found that there's a critical stenosis of both carotid artery which are supplying the brain. Angiogram is done, which is showing critical stenosis of the left carotid artery. This is our common carotid artery, external and internal, which is going towards the brain, and there's a critical stenosis in the origin of the ICA leg. And the right side is also showing about 70% stenosis. So we are going to immediately do an angioplasty instead of the left common carotid and ICA. Both, we will just put a stent from the ICA and to the bifurcation into the CCA. Let's go ahead and see how the procedure will be done. Thank you so much. So we are, can you give me a roadmap here? Wasn't you able to show the screen?
Yeah.
We can compose that side. So it's a very tight stenosis that we see. So, we have gone into the lingual. That was just a stage. So Mr. Raju, who is a 61-year-old man suffering from a repeated transient ischemic attack. So what is a transient ischemic attack or a mini stroke? Can you check a roadmap outlook?
Sir,
Kadalpandi Raju garu. So this is done with the local anesthesia. Now, mini stroke is basically ischemia of the brain, which produces a stroke-like symptom, which typically lasts for about 3 seconds or a minute. Previously, we had a definition that any stroke which lasts for less than 24 hours used to be called as a mini stroke, but now we consider it about 15 minutes or less is a mini stroke. If it's more than 15 minutes, we consider it as a full-blown stroke, and generally don't reverse without treatment in terms of thrombolysis or thrombectomy. Now the question could be, what is the treatment for stroke? Now basically stroke means there is a less blood supply to the brain, and so the treatment of stroke previously used to be medical management, blood thinners and other things. With advent of medical sciences, now the strokes are treated by two major mode of treatment. One is thrombolysis, where we inject thrombolytic agent. So thrombolytic agent can be given intravenously, which is called IV thrombolysis, for 4.5 hours. And they are acrylase and tenecteplase. Two molecules are available. Both are very like they do well for the stroke patient, but that can be given 4.5 hours in the onset of stroke. Beyond 4.5 hours, these medications, so these drugs are not recommended. So, but thrombectomy can be done up to 24 hours in selected patients, and most of the patients up to 6 to 8 hours. In thrombectomy, what we do is we put a small puncture in the groin, we put a large bore catheter till the neck, a small catheter is navigated into the brain, and we pull out the clot. Here also we have taken a puncture in the groin, and we put a large bore catheter which is gone in there. So here we simply carotid stenting will do, because the patient has not yet developed stroke. So, so this carotid stenting will be done as a protected carotid stenting, where we will put an umbrella-like device beyond the stenosis, and when we are doing angioplasty, putting a stent or a post-stent dilatation, any clot if it goes beyond the stenotic area, that will be caught in the filter of the umbrella and which can be pulled back. Let's go ahead, please. Pull up hypertrophy. So we are going ahead with distal embolic protection in forms of important. Cut it. Where? Atropine given? So you given 1 ampule of atropine for, because the carotid body might get massaged, so patient might go to hypotension. To prevent that, okay. So I'm just trying to take the air out of the filter. Perfect. So just putting the filter inside. So this is the distal embolic protection which we will deploy beyond the Give me a roadmap. Can I have a roadmap? Roadmap. So we are trying to take the distal embolic protection, which is very, very important when we are doing the carotid stenting. And this is going to prevent any kind of embolic material that could possibly go from the lesion up into the brain. That could be catastrophic. So crucial, but here are the top cut off. So it is a very critical stenosis which you have to navigate through. Thank God. Yeah. So here the filter is independent of the wire, and I have taken the wire really all the way into the camera segment. I want to put my filter in a straight segment in the upper cervical behind, just below the petrous. So this is a very nicely placed thing. So can you just take out the roadmap and give me some mag? We will show how the filter will be deployed. Table please. Mag. One more mag. So this is the filter which we are going to deploy here. Basant, can you show the filter here? So it's very nicely there in the right segment. And now you see that we have just placed the filter beautifully. So Parvati is with me along with Gauri for past 10 years as a team. Basant is with us, who is today doing the camera, and our team of anesthetists. You can tell this is our anesthetist. You can introduce yourself and tell something. This is a global live. Tell your name and she was my junior. She is Dr. Archana, and she is our anesthesiologist for many of the procedure, and she is an expert doing neurovascular anesthesia. And we are so happy when she is around because the anesthesia part is really well taken care of. Table please. So we can see that the lesion is here, the filter is here. Now we are trying to go ahead and do a little bit of angioplasty, open up the vessel before we deploy the stent. Raju garu, kadaloddu. Kadaloddu. Malapartin kadaloddu. So you can see our axis, the lesion and the filter. Maatladadu. Give me the balloon. We can dilate the lesion a bit. We can also take the stent, deploy and dilate, but it's better to prepare give me the So carotid stenting has been a procedure involved for a long time, and there are basically two procedures which address these carotid artery diseases. One is called a carotid endarterectomy, which is surgical procedure opening the neck and doing endarterectomy, and this is without opening the neck. And we are talking to Raju Garu, and he's absolutely fine and fantastic. And then we are doing the procedure which is called the carotid artery stenting with distal umbilical protection. Both are very competitive and excellent procedures for carotid revascularization. And we have done over 1,500 carotid stenting in the last 16 years with excellent experience of doing it. So let's go ahead and see what happens next.
అదే 620
14 plus
620 ఉంది కదా ఇప్పుడు.
అదే
So looks perfectly in control. Can you give me a roadmap here? Go ahead. Go ahead. Next, next, next. Keep going. Keep going. Keep going. So basically, Gauri is doing the cath lab technician job. She is expert in both the work. Yeah, roadmap on that. So taking a smart mask here, so that a little bit of bed preparation. But if you are taking something like a C-guard, you must prepare it well. Otherwise, you can have problem removing the deployment system. Or exactly. I don't know. Listen. Stop. Deflate. Listen.
హెల్త్ వెయిట్ చేయండి
Roadmap out. కాదలొద్దండి, కాదలొద్దు రాజు గారు. నో టాకింగ్, మాట్లాడద్దు, కాదలొద్దు. So that's a little bit of disadvantage when you are doing it under local anesthesia. The advantage a lot many compared to the disadvantage. Roadmap on that. Keep running the sun. Keep running. Yeah, keep going. Very good. All right, don't work on that. Okay, go ahead. Slowly. So we'll just clear a little bit. Wait. Deflect. So we are very happy here, comfortable, because we have our dyslipid protection. Not good. So there is no worry, there is no hurry. We are going very slowly, very nicely. Deflect. So almost we are done with this. Hold the wire. Roll it out. Beautiful. So everything looks perfect. You're all under control. It's very important for us to go step by step in a very comfortable manner and ensure that your dyslipid protection applies. Now we'll go ahead with the stent. Can I get an exact 6640? So this is the first balloon. We will get a right contour out of the stent. So one it out. So this is a closed cell design. Okay. So this is a closed cell design stent. We have open cell design stent. We have hybrid stent called C-guard, and there are very many stents available. Here we are using a closed cell design exact stent, which is a little stiffer stent. And basically the advantage of exact is It doesn't allow any kind of embolate material to come in. If at all, then there's an umbrella-like device which is called an AP6. And if you're using the open cell design, the indication could be you have a tortuous carotid where you want the conformation of the stent to the wall. This will not approach to the wall very well, so it's tortuous anatomy. So for straight anatomy, this is fantastic. So we have a straight anatomy here today, so we are using this. Otherwise, you could have used open cell design. The hybrid stent, the Seaguard, is even better, but that's again stiffer and it's a bulkier system. You need a little expertise to do that, which we'll keep doing in many places. And the problem could be with the Seaguard is when it's a very critical stenosis, you might have trouble bringing back the delivery system for nothing. They are quite comfortable. Heparin is given. Total heparin how much?
Total 3,000.
Give 2 more thousand anesthesia team.
2,000.
2,000 heparin please. Given diphosphorus here.
Even
So we have our stent across. So if you want, you can do a check angiogram here to confirm your position before you deploy. The 2,000 heparin given. So it's a good position to be. Maybe we will withdraw a couple of millimeters as we deploy the stent. That will be nice. As I said to you before deploying that this is a stent which can actually straighten the vessel. We are very well seeing here. I just withdrew a couple of millimeters before deploying, and now I'm going ahead, and this looks perfectly okay for us. That's very nice, as we see. So this is very comfortable. Roadmap output. Raju, all okay? So the best thing is in local anesthesia, you can keep talking to the patient. You can do an assessment of general condition, and neurological evaluation can be done. We can just talk to Rajgaru for a minute. Rajgaru, okay? It's a student, we paid the fantastic. So this is the advantage of being in a local anesthesia. Movement and table అయిపోయింది. Table please. May I talk to you for? Okay, enough. Can I have the balloon? One mag more. So we will do a little bit of post-stent dilatation to improve the caliper. And without the dilation, first let's look at the caliper. This looks perfectly okay. So little bit of improvement at the mid of the stent, at the level of the stenosis, will make us a little more happy. So the recommendation is go and try to make it as close as 80% or more. Good. So the reason for go, stop, different. So this is perfectly okay for us. We don't want to get more, not required. You have to be very careful when you are doing this dilatation, post-stent dilatation for embolus, as well as the patient might get sick a little bit in terms of the blood pressure going really down, or the patient might just experience a little bit of seizure kind of thing. So you should know where to stop. This looks perfectly okay for us. You don't overdilate because you might rupture the carotid duct. It will be catastrophic. You need a lot of experience to understand how much you can really go ahead. So let's look at the caliber of the carotid right now. I'm super happy. I'm super comfortable. This looks absolutely awesome. Go back one. Go back one. Go back. 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 Yeah. So you can see the caliber, the apposition of the stent, proximal distal, absolutely fantastic. The lesion which is there almost gone. Now we will retrieve the filter, the NAV6. So we could capture the distal ammolar protection device and just pull it out. This is how it is. Absolutely good. Thank God. Stop. Go back. Go back. No. Yeah. So this looks perfectly okay. This is how the lesion looked like before the stent. This is what you have after the stent. Mag toku change. Inka toku. Okay. Wow, this is wonderful. Really thankful to God for this fantastic result. Table please. Cover the head. One mic. Cover the head. One mic top. Mic top. Mic less. Inka. Table please. One more. Yeah. So our cath lab technician is a very big Rajnikant fan, so he decided to go for a night show, Mr. Prasad. So we are missing him badly because he's not here, unfortunately. Epicranial. So you can see, always you make it a point that after carotid stenting you look at cerebral plasmacytogram for table please. Mag. One more, yeah, good. So after the carotid stent, we should look at the cerebral circulation without fail, because if there is some missing branch, we will be able to do a thrombectomy or aspiration if required. Table please. Extremely good. So thank you so much. So we are done with the carotid artery stenting with distal embolic protection, and I really thank our team, including Parvati, Gauri, Dr. Archana, Basan, and my good friend, and Ram, who is in the team also. So thank you very much, and have a good night. Thank you so much. See you later.